Good morning. Good morning, everyone, dear colleagues and friends, and ladies and gentlemen. I hope everyone had a wonderful time here. It is a great honor to present at the final league of the 2024 Mega Mind. My name is Jung Kim, and I'm from South Korea. Today, I'll be presenting on the title of Aesthetic Harmony between natural teeth and implants. To briefly introduce myself, I'm a board certified periodontist, and currently I serve as an adjunct professor at Seoul National University Dental Hospital, and I also run a small private dental clinic in the city of Seoul. This is my clinic, which is Meister Dental Clinic. From this location, after a total travel time of 17 hours, it is a privilege to have arrived here at the beautiful Hotel Martinez in the city of Cannes. One hot summer day, in my clinic, a middle-aged man came in almost dragged by his wife, holding her hand. When he arrived and sat in the unit chair, he barely opened his mouth and was filled with distrust and fear of dental treatment. I treated him very kindly with a bright smile as one treats a child. Eventually, he asked me, "Can you make my front teeth look more beautiful within 2 months?" Just 2 months. After an oral examination, even though it was a highly challenging case for me and I didn't have enough time and confidence, I said to the patient with warm smile, I would give it a try. This is the initial panoramic X-ray, and let's first focus on the anterior region and discuss the treatment plan. Starting at the maxillary right anterior teeth 11 and 12, periodontically, they were severely compromised with greater immobility and very thin buccal bone plate. I planned immediate implant placement and provisionalization with simultaneous bone grafting. Next, for the maxillary left anterior teeth 21 and 22, they were far from the ideal arch due to severe rotation and crowding. Thus, I planned intentional root canal treatment along with soft tissue grafting. In the mandibular anterior region, we can observe heavy calculus deposition, and specifically teeth 31 and 41 were floating, and 42 was also periodontally compromised. I plan to extract all three teeth with immediate implant placement and provisionalization. The total treatment plan that I've talked about so far is as above: immediate implant placement and provisionalization, and intentional root canal treatment. Here, you can see the current status of crown width ratio, gingival line, and incisor line. For the gingival line, we plan to improve it using connective tissue grafting. The crown width ratio and incisor line would be adjusted using a PMMA provisional restoration based on diagnostic wax-up. For the mandible, due to space limitations, the final prosthesis was also planned as 3 incisors as it is now. In the current state, after taking impression, I performed diagnostic wax-up and fabricated provisional restoration, which will be used as a positioning guide for implant placement. Here, the fixture positions are planned, and we drilled holes on the provisioner. And we completed the extraction and fixture placement and final abutment connection. And I immediately set the prefabricated provisional restoration, which was used as a positioning guide. This is healed state after 2 weeks. In the maxilla, the initial teeth alignment was significantly deviated from the ideal arch. I plan to distribute the space for the central and lateral incisors like this. First, we intentionally fractured the crown of teeth 11 and 12 to induce slight gingival overgrowth. And next, for teeth 21 and 22, intentional root canal treatment was performed. After 1 week, slight gingival overgrowth could be observed in this clinical photo and also in a schematic drawing here, white arrows. In addition, I did resin buildup on the parallel side of teeth 21 and 22, guiding them into the ideal arch. From the front view, I simulated the delivery of the imaginary temporary teeth and fabricated the temporary shell by hand. Finally, I delivered the first maxillary provisional restoration. From the occlusal view of this provisioner, the width distribution is well balanced, and this provisioner will be used as a positioning guide for implant placement. We made holes in the proper position and extracted the remaining roots. And then placed the fixture uh, and connected the final abutment immediately, not a temporary abutment. After slightly modifying the abutment, I planned the incision design for hard and soft tissue augmentation. An incision was made between teeth 13 and 23. On the right side, hard tissue augmentation was planned using GBR, and on the left side, soft tissue augmentation was planned using CTG. For the sake of predictable hard tissue augmentation, I used allograft for intra-socket grafting, xenograft for extra-socket grafting, and covered it with collagen membrane. On the left side, I performed connective tissue grafting with chronally advanced flap. After grafting on both sides, the flap was sutured at the desired level by releasing incisions. Then I installed the provisioner, which was separated between implant side and the natural teeth side. From this initial state, let's take a look at the process of hard tissue augmentation. This is the CBCT sagittal cut of tooth 12. You can see the very thin buccal bone plate. As shown schematically, the periodontal condition was very poor. First, fractured the crown. After 1 week, slight gingival overgrowth could be observed. Then extracted the remaining roots and placed the fixture and connected the final abutment. Then elevated the flap, and I grafted allograft into the intra-socket area. For the extra-socket area, the non-resorbable xenograft was used for volume maintaining. I used collagenated graft material, carefully compacting and shaping it, then covered the graft with collagen membrane. I made releasing incision for tension-free primary closure. Finally, the provisioner was set. Let's take a closer look at the bone regeneration mechanism in this area. Actually, I had a chance to write a paper on this subject as a first author in 2016. And this was published in Clinical Oral Implant Research, the COIR. According to my paper, a distance osteogenesis from the socket wall, here from the socket wall, and contact osteogenesis from the graft particles, here, graft particles, occur together. Then it accelerates the bone regeneration. In other words, the distance osteogenesis from the socket wall and contact osteogenesis from the osteogenic cells attaching the graft particle surface combine to promote the bone regeneration. And in addition, I expect the yellow allograft will be resolved over time and replaced by the autogenous bone after a long time. This schematic is my ideal goal. The auto bone consists of the area around the implant, and the non-resorbable xenograft maintains the buccal soft tissue volume. In this angle, we can observe how GBR increased the volume and CTG thickened the gingival tissue. When comparing clinical photo taken right away after surgery, 3 weeks later clinical photo shows the slight stabilization of gingival margin. From this angle, there is still some redness and swelling in this area where CTG was performed. It can be seen more time is needed for further stabilization. In the front view of the 3 weeks clinical photo, when compared to the initial clinical photo, the overall alignment of teeth and gingival symmetry improved a lot. In the panoramic comparison, fixture placement and root canal treatment have been successfully completed. In 5 weeks clinical photo, gingival tissue was more stabilized than before. However, we are not ready to take a final impression because gingival maturation is not completed. But we had only 2 months. That's why we took the final impression at 5 weeks. The stump model of provisional restoration, which reflects the patient's requirements, could provide the detailed information to the dental technician. Using software, the shapes of the provisional were superimposed on the abutments and the prepared teeth. In reference to this morphology, the final restoration could be designed. These are post-sintered crowns, and after cutback procedure, first build-up, second build-up, internal staining and glazing were performed. Through the laboratory procedures, eventually, the final process is delivered like this. I try to match the shade of the restoration naturally with the patient's original yellowish teeth. And I expect the gingival maturation more. Here you can see the final panoramic X-ray. The total treatment plan was successfully completed. Now we're going to review the entire treatment process from the beginning and wrap it up. This is the initial state. After surgery, you can see the immediate loading and provisional state. 3 weeks clinical photo shows the slight stabilization of gingival margin. And we took the final impression at 5 weeks. And this is the final prosthesis. Gingival symmetry as well as teeth alignment in maxilla and mandible improved dramatically compared to the initial state. And the natural teeth and implants are aesthetically harmonious. Since the final abutments were connected immediately instead of temporary abutment, there was no disconnection after surgery, which prevented trauma to the mucosal seal from multiple connect-disconnect procedures. Now this is the end of my presentation. I'm truly grateful for the dramatic dental and facial improvements, but what touches me even more is how the patient's initial distrust and fear of dental treatment transformed into trust and relief. Thank you for your kind attention, and thank you for joining me in this presentation. Thank you.